cases, the treatment can go on for the treatment can get over within a minimal appointment or within a shorter time. But when it comes to difficult cases, crowded cases and all, I will say that clear aligners will also go on for a longer time. The treatment cannot get over within a short time, because in fact a nickel titanium wire can do a faster work in a very severe crowded cases compared to aligners. So only for specific, easier, simpler cases, aligners can reduce the treatment time. Aligners can have a minimal clinical visits, but for a crowded cases, maybe equal to braces, the duration will be required. Results are not visualized in hand when it comes to braces, because there is no software involved, there is no artificial intelligence predicting the outcome. Wherein take any aligner software, take any, these days even intraoral scanners are attached with the artificial intelligence simulations of the malocclusions. But whenever you're explaining or whenever you're showcasing the results from the AI, please tell the patient that the plan may not be as same as the AI simulation that a intraoral scanner attached apps will be given. What happens is, usually you show the immediate simulations, the patient thinks that it is going to be 100% the same. Put a word that a customized plan, wherein every bone, other tissue of your face, of your mouth will be taken into consideration, and a 100% customized plan will be made, and that's how we will be giving you your final report. So but the best part is, once the plan is made, once you have taken the 3D data, once you have made the plan, you can show the patient this is the end result. So we are more confident, we are starting the case with the end result in the mind, wherein doctor is also more confident, the patient is also more confident. Obviously, because of these major reasons, adults higher acceptance rates are towards aligners, because they are virtually invisible, it doesn't affect their lifestyle, more convenient. When it comes to they, as they get older, their tolerance for pain and everything might reduce, so they look for more comfort and convenient treatment options. So fewer emergency visits, their lifestyle may not permit them to come back the next day to get a debonded bracket fixed, to get the poking wire to be cut. So adults might have higher acceptance towards the aligners. And the sheets that are used in aligners are the PETG sheets, polyurethane sheets. Braces, they are manual placement of the braces. These days, we are also getting custom-made brackets for the individualized prescription of the brackets. But again, that is not more so commonly used. But when it comes to aligners, it is 100%. A set of aligners is 100% made for only for those patients. Everything is pre-planned. Software gives us the plan, so you can explain to the patient, then proceed with the treatment. Aligners mainly exert push force, wherein braces exert pull force onto the teeth. And when it comes to braces, why are we saying minimum it requires 8 to 10 months? It has to go through three stages of the treatment, where initially we are just trying to level and align. In second stage, we are trying to close space. In third stage, we are trying to express torque, and also we are going towards the finishing and detailing. What happens here is, you cannot skip any step. You need to follow sequence of wires. You need to follow these mechanic sequence. Then only you can debond, leave it in the stabilizing phase for some time, then only go for the debonding. So any simple case will also take so much time when it comes to braces, wherein that is not the case with aligners. The here, more the plastic coverage around the teeth, more the surface area covered, better the tooth movement. Extremely smaller teeth, there is no surface area to be acted upon, so the response of such tooth can be little unpredicted, wherein anatomy should be of at least normal range for an aligner to act nicely. Anchorage control is good when it comes to aligners. There is no unexpected anchor loss that happens. You need to plan accordingly in order to preserve the anchorage. So aligner sheet properties, aligner material properties are the ones which actually determine the tooth movement, and hence the whole process of thermoforming also needs to be carried out thoroughly in order to for an aligner to express the forces and to bring about the tooth movement. Most of you who have already been working with aligners, you will know the steps involved in the aligner treatment. First is initial consultation, wherein you will explain to the patient what are all the different treatment options. If you need to get into the field of aligners, firstly, you have to start giving this as one of the treatment options if the case is suitable. All this while, you were consulting a case by saying what are all the different orthodontic treatment options: metallic braces, metal self-ligation, ceramic self-ligation, lingual braces. So you also need to add on aligners into the list. And after the basic consultation, maybe you'll show a demo aligner which you will be having. This is how it looks like. After the initial consultation and the case is suitable for the aligners, you will go ahead with the intraoral scanning. Intraoral scanning, or the one option is intraoral scanning. The other option is indirect way of collecting is procure a cast, then send it to the lab for indirect scanning. That is also an option. Once the 3D data has been recorded, you will be planning a case under the software. The software tells you exactly how many trays will be required, how many stages will be required. Once that is done, individual stage case model will be exported. That will be 3D printed. Once the 3D printing is done, a sheet, a thermoformed sheet will be pressed onto the model in order to get the aligner sheet. Suppose the case requires 20 sheets. Always better not to print all trays at once. Remember, when you're asking for it, unless the patient is traveling somewhere abroad, not available, the patient will not be coming back to the treatment. That is the only time when you'll ask for bulk printing. Otherwise, go step by step. Just ask for 5 sheets at a time or 8 sheets at a time based on the case difficulty. Because in some of the crowded cases, if a case is not tracked properly, you always have an option to rescan and replan and continue with the case. So better to go for, incremental printing and not the bulk printing. Today's technology has come up with something called as direct printed aligners as well, wherein the step of printing a model is also eliminated. Once the planning is done, once the segmentation or the stages have been done, directly you can print the aligners. You are skipping the step of 3D model printing, and also pressing of these thermoform sheets has been skipped. So you can see here, after the planning has been done, once you have gotten the exported files, you can directly go ahead and print the aligners as such. So that is some Graphy company has come up with direct printed aligners that is also having a property of shape memory. So it is giving much more promising results compared to the present day sheets that we are using in aligner industry. You can see here, if you ask me, the first image is from a cast. You have taken the cast, send it to the lab for intraoral scanning. You can see some irregularities here. You can see some irregularities here, but it really doesn't affect the treatment outcome much. So you can proceed. If intraoral scanning is not an option, then indirect way you can procure the 3D data. This is where direct intraoral scanning has been done. How much area do you really need to cover? It is not just the teeth, even the surrounding gingival structures of around up to 3 to 4 mm on the buccal and the labial side, labial palatal side, lingual side, you need to cover. What is most important is the good data that you given. There is always a GIGO principle: garbage in, garbage out. If you give us a good data, we'll be able to process it better. If you give us a bad data, ultimately we will also be coming up with a bad outcome. That tray may not fit, tray might have a void, tray might have additional bleps on the trays. So that's why try to give us a good data. I'm not just talking about the scans. Along with the scans, I will also be talking in the part of diagnosis what additional things you really need to send us along with the scans for us to do a planning. Most of the time what happens here is, I'll be sitting and planning. I don't know which gender the patient belongs to, what age group the patient belongs to. I'm just sitting with one STL file. No, that should not be the scenario for a planning orthodontist. You need to create a clinical scenario for us also to plan, for us to understand what the case is. Can I procline? Can I retrocline a tooth? So you need to give us the exact clinical scenario for us, then for us to give a better plan. Coming to few of the basics of tooth movement with the aligners. Remember, you have given aligner. The patient will start saying, uh, ma'am or sir, the aligner is not fitting 100% onto my tooth on the first day. Yes, it is not made to sit 100% perfectly on the first day. As we just priorly mentioned, it is made on the corrected position. It so that tray will take it into its position after 3 to 4 days. First day, second day, the tray is not comfortably sitting on the patient's mouth. It is not 100% snugly fit on the initial 2 3 days. So you need to reinforce on the fact that yes, that is an indication that the teeth is being moved. You will have some discomfort. There will be mismatch between the aligner and the teeth in the initial 2 to 3 days of every tray that the patient is going to wear. How long should the patient wear every tray? For 2 weeks. That is, for 15 days, you'll be asking your patient to wear every tray. For even if you're thinking about giving aligners to a patient, from the day the patient walks into your clinic, you need to check one factor, that is compliance factor. Is he a compliant patient? Especially teenagers, if you're planning to give aligners, ask their patient, you evaluate by different methods, is he going to be a compliant patient? If the patient is not wearing and he is just going to lie that I'm wearing the trays and no results have been seen, even the clinician is stuck, right? So before giving aligners, evaluate for the factor of complaints. Ask them, are they going to be a promising patients and consistent patients in wearing the aligners? In a day, how many hours are they supposed to wear? Just now we discussed, for every 15 days, they are supposed to change to the next tray. Every day, in each day, roughly somewhere about 20 hours. That is how much is practically possible, because while brushing, while eating in the morning, afternoon, night, snacks, including all these intervals, they can practically wear, you instruct them to keep it in mouth for 24 hours, but they will be practically be able to wear it somewhere around 20 to 22 hours a day. Instruct them with this one special instruction saying, no, for not more than an hour, it should be outside the mouth. What happens is the teeth is moving. They'll keep it outside the mouth for 2 to 3 hours. Again, in that moving phase, the teeth easily tries to go. There is always a tendency for it to go back to its original position. So longer the time, the force has been in the zero level, the teeth will obviously go back to its position. So tell them, within an hour, try to wear it back. Let them take breaks. Within an hour, they have to wear it back, and not more than 2 to 3 times. Not frequently, they are even supposed to remove it. It should be in the mouth. It should be exerting force for the tooth movement to happen properly. Constant monitoring is necessary. If somebody is telling just give the trace and send the patient, no, that is not the way. That is not at all a promising way to treat a aligner case. Constant monitoring, especially when it comes to crowded cases or wherein interproximal reduction is involved, you need to call the patients. Maybe you may not call them every month. You can keep it once in 1.5 months, once in 2 months after giving 4 trays, but make sure you have done all the clinical procedures that is required for the patient to wear those 4 trays at least. So don't just send the patient unmonitored, because you always need to track the case. You need to hold the plan, see at the first stage how much tooth has moved on the system. Is it moving in? Is it happening clinically? What happens is, we can plan any number of permutations and combinations on the software, because it doesn't have bone, it doesn't have blood vessels, it has no limits. I can just move 8 millimeter, 9 millimeter, but that is not the same when it comes to clinical scenario, right? So you always need to keep a keen check on what the plan has been given. Is it practically possible? Is it clinically possible? And stop at every stage and you compare that with the patient. You have given the patient 2 trays. The patient is coming after a month. You go to the second stage, stop at that stage, see how many degrees of correction was expected in the plan, and try to see if the same thing is being simulated clinically as well. So, keep an eye on, and constant monitoring is at most required. Mid-course evaluation and refinements may be required. I'll be talking about this in the later stages. What happens is, overcorrection is required along with the present technology that is available. Uh, because we are not able to reach 100% promised, whatever we are planning, we are not able to reach it clinically. So in order to, we are landing up with 80% of the results, 90% of the results. Another 10% is again left out. In order to cover up for it, little bit of overcorrection is required in the plan to, give approximate number of estimate for a case. Posterior open bite is noticed after 1 to 2 months of wearing aligners. If some of you are already treating cases, you will know one good thing is posterior open bite after 2 to 3 months. If you notice in a patient's mouth, good thing is the patient is wearing regularly. That is an indication that the patient is wearing for 20 to 22 hours a day regularly the aligners. One more discomforting factor is that the patient will start complaining about inability to chew properly. The teeth are not being touched, so he will have difficulty in chewing. He will complain about this. How do you deal with this posterior open bite? Why is this posterior open bite happening? Around 0.7 mm of one lower sheet, up around 0.75 mm of upper sheet, all put all together 1.5 mm of sheet is being always pressed upon by the molars. That is causing constant intrusive forces on your upper and lower molars, from premolars to the molars. So that's how all those teeth are going in for intrusion. So you'll see some amount of posterior open bite. One way is to let it naturally settle by asking them to achieve post-treatment. You have removed the trace. Naturally also you can let it settle. But if the patient is telling it is way too much of discomfort, then there is a way, like you can also place buttons and you can start giving settling elastics. You can place buttons and also you can start giving settling elastics, intraoral settling elastics you can give. That's how you can close the spaces and close the posterior open bit. There is also one more way to do it. If a less number of trays, you can start one arch initially, like 1 2 months earlier, and then start the other arch treatment after 2 months. Maybe because you're ending with one arch at the earliest, that's when the teeth will have freedom of movement and they will try to erupt back to their original position. Whatever is being intruded, they try to erupt back to their original position. So the amount of posterior open bite can be reduced if you can start one arch treatment little earlier compared to starting both the arches at once. So how many of you actually know the word meaning of the word tracking, backtracking when it comes to aligner field? What is meant by backtracking? Can any one of you message? What is meant by backtracking? Okay. Firstly, what is the word tracking means to say that is the clinical result going as per the plan that has been given to you? As I told you, all of you should be in a position to evaluate the plan that has been given. Stage wise, just check, is it going clinically smoothly as promised by the plan? So that is the way you will be checking if a case is being tracked properly. What is that one best indication that a case is being tracked properly? The next tray should fit properly, and that there is no rocking of the tray, there is no lifting of the tray, it's there is no abnormality, there is no abnormal fit in the next trace, is an indication that the case is being tracked properly. When you put across the next tray, almost like I'm not talking about the 100% fit, that little mismatch will be there, but most of the time it sits properly onto the teeth and it again starts to act. That's how you say that the case is being tracked properly. Backtracking is a term wherein you will go back to 3 to 4 trays and ask the patient to wear it again. When do you do it is, you can see in the first diagram, the tray, this particular extrusion of a tooth has not taken place properly. There is a gap between the tooth and the tray. That means the tooth was supposed to move till this position. There has been some lagging. This is the position, this is the time you interrupt, ask them to go back to the whichever tray was fitting properly. Like suppose here the patient was in 8th tray, but 5th tray was the most accurately fitting tray. You will ask the patient to go back to the 5th, create if further spaces are required, and that's how you will, ask them to repeat the trays for next another 5 days or 7 days in order to complete the incompleted tooth movements. So these are the issues during the treatment the patient can come up with. Gap between the teeth and the tray being lifted at once, tray is too small, tray is too large. These are the issues wherein if some of the tooth movement have not been completed to 100%, they'll encounter with such issues. What are all the few other issues that the patient can complain about? Maybe he just becomes non-compliant, he is not wearing, or aligner starts becoming uncomfortable. When do they become more uncomfortable? When the fit is not proper. That is when they'll start complaining about the uncomfort in wearing. They're not fitting at all because of the incisal gap. They're either too big or too large. It starts rocking, it starts getting lifted on one side. So there are some tight proximal contacts. If you have not cleared them, that is also the time when aligners will stop working. You'll just be continuously giving the trays, but the work is not being done. That's when the tray will not fit after 2 to 3 trays. So there is no complaint of fit issue, means the case is going on smoothly. Once some fit issue starts, that is the time you really need to interrupt and see, have I created sufficient space, or is the patient, you should also first doubt on whether the patient is wearing regularly or not, or really has there been some manufacturing defect, that is the reason why it is too big or small. So that is when you need to actually interrupt, do the mid-course evaluation, then further continue. If required, you will have to even do rescanning of the particular case. Here you can see there are, it's a graph wherein green line indicates the planned or the promised result, wherein actual tooth movement, clinically, we are able to reach up to 60 to 70% of the overall results only, because of so many technological issues, or the ability of this plastic to move teeth is only limited to so much. Whatever 100% is being promised, 60 to 70 we are able to reach. Here comes the role of the refinements. Here comes the role of refinements, where you again rescan and give additional trays to cope up for the whatever treatment has not been completed properly. So here, for all of you to know the basics of the orthodontic tooth movement, what does the tipping? The word tipping refers to the mesiodistal movement. Crown tipping refers to mesiodistal movement of the crown. Root tipping, again the same thing, mesiodistally. Coming to the torque, torque refers to proclination or the retroclination. It's the labiolingual movement of a tooth that is called as a torque. So if only the crown torquing, root torquing, you can see here. Tipping is mesiodistal, torquing is proclination and retroclination. And when it comes to rotation, how many of you think that rotation is a easier tooth movement with ortho, or is it a difficult tooth movement with orthodontics? And does it have a high relapse tendency? I think most of you will agree with me that rotation is a difficult tooth movement as such with the braces. Even it is much more difficult with the aligners, and it has high relapse tendency as well. Extrusion, almost think like extrusion is moving away from the socket into the oral cavity or towards the occlusal table, but this is almost an impossible tooth movement with the aligners. You're sitting inside the car and trying to push a car. Imagine this, will this happen or not? No. So that's how you're trying to grip on to the teeth and trying to pull it down. That is a little difficult movement with the aligners. Intrusion, because just now we spoke posterior open bite is happening because of the posterior teeth are going for intrusion. Anterior intrusion is not so promising. If you are advocating 1.5 mm of intrusion, around 0.2 to 0.3 is happening clinically. So that is the amount of lag that you can see. Only 30% is being expressed. 1 mm you are indicating in the plan, only 0.2 to 0.3 is happening clinically. So anterior intrusion is again a little bit of questionable movement. Bodily movement is difficult with aligners. Distalization has come up as one of the most promising tooth movement with the aligners, wherein mesialization is difficult. The trace will start getting lifted, so mesialization is little bit difficult. Expansion with tipping of the teeth, buccal tipping of the crown is possible. Bodily movement of expansion is again difficult with the aligners. Proclination, yes, it is one of the easier movement, but don't, just go ahead and give a lot of proclination of the anteriors wherever you need to solve the crowding cases, because you are forgetting the fact that uh, buccal cortex can give up at any point of time and can lead to fenestration and dehiscence. They'll say we will convert a non-extraction case into non-extraction by doing a lot of IPR and interproximal reduction and proclination. Don't believe that if a case has to go for extraction, it has to go for extraction if you're putting braces or with aligners. Remember, you cannot suddenly make an evident extraction case into a non-extraction one, because you're there. What happens is the bone is, you're severing the bone, you're severing the gum tissues. At the same time, enamel is being taken off in the form of interproximal reduction. So proclination is a part of gaining space in aligner treatment, but don't use it inabruptly in such a way that the bone and all gives up at one point of the treatment. Lingualization, this is what exactly happens during space closure. All the teeth are being moved towards the center of the oral cavity. This is one interesting slide. All of you can see here the predictability. Yes, we are saying, we are promising 3 millimeter of intrusion, 20 degree, 30 degrees of torque in the plan. Uh, all of you start asking for the report of individual tooth, how many millimeters, how many degrees of torque, or how whatever correction is being done in the plan. You will get a report of like how much one is being moved mesiodistally, how much it has moved labiolingually, how many degrees of rotation has been done. Take the report, and in excessively, if any tooth movement has been advocated in the plan, that is not a case for aligner. You need to make the severe case into a moderate case by braces or by hybrid method or by some orthopedic appliances, then subject a case to aligner. uh, Case which requires 50 degrees of rotation correction of a premolar, upper premolar or lower premolar, and you're expecting that correction with aligners, this is something which is not happening in any time. So know about how much it can truly express, know how much it actually works. Distalization, we were just talking about, especially the upper arch distalization for a class 2 issues is gaining a lot of popularity because of the nature of the maxillary bone, and also the way aligners can actually, after removing the 8, what they will do is sequentially first they'll take back the 7s, make it after 7 has been moved, then 6 will be moved back, 5, 4 will be moved. So class 2, some of the class 2s are being nicely corrected with the distalization. Even the predictability is good. The predictability of distalization is good. Expansion, I was just talking, expansion with buccal tipping, yes, it does happen, including the molar and premolar buccal tipping will happen, but not the bodily movement of bodily movement. Tipping, tipping, you can see the percentage up to 80% you can predict it happens. The tipping predictability is also good. Expansion, buccal tipping related expansion is good. Distalization, 88% predictability is there. Rotation, you can see we have come down to the percentage of 45. Rotation of anterior teeth is good with aligners because they are flat, mesiodistally they are wider, labiolingually they are thinner. The holding of the teeth with the tray is good. That's how you can derotate anteriors nicely. Wherein once you come back to posteriors, the round bulbous teeth, so much holding of the tooth is not there. So that's how it fails to express the rotations, irrespective of how many attachments you try to give on both labial and the lingual side. Mesiodistal tipping, yes, given a proper attachment, the predictability is around 40 to 50%. torque also gets expressed, but you can see 30 to 70%. So if you are expecting 20%, 20 degrees of torque, you definitely need to incorporate more torque in the plan. Understood, right? So 20-degree torque is what you want to see clinically. Somewhere 40 to 45 degree on the plan you can incorporate. So that's how you need, that's where the role of overcorrecting in a plan comes into the play. Intrusion, you can see hardly 30 to 40%, especially the anterior intrusion. Posterior, no doubt, it is just squeezing the posterior teeth. Posterior intrusion is happening, but anterior intrusion is difficult. Predictability is 30 to 40%. So for every 0.3 mm of intrusion you want, you have to incorporate 1 mm intrusion being applied on the plan. So that's why I asked you to take the report wherein you will get to know how much each teeth has been moved. Extrusion, they say 30%, but I say don't even attempt extrusion with the aligners, or else you'll be just expecting, you'll be over promising to the patient, but that is not happening clinically. This is just for you to know how flatter teeth, anterior teeth, have a good predictability when it comes to intrusion or tipping or rotation. But as you go towards the bulbous and the round posterior teeth, the predictability of the tooth movement starts reducing. So these are some of the aligner auxiliaries. We were just talking, what if some space is still left without being closed? That's when you will start giving hooks, you'll start giving elastics, extraction space closures. You will, from the starting of the plan itself, you will place the hooks onto the teeth and start giving the intraoral elastics. For extrusion of a particular teeth, if it is not happening, you can see button, composite button and an elastic, or a ceramic button and an elastic that is being given. Further, see, we just spoke posterior intrusion is good, but what if you need further intrusion? They are taking the help of temporary anchorage devices in order to give more intrusive forces through elastics. You can see elastics being run from buccal to palatal side. So that's how hooks, intraoral elastics, buttons, and then the temporary anchorage devices. These are all the auxiliaries in order to cope up with the laggings, that are inherent laggings that are present in the aligner system. You can see, since the anterior corrections were much more simpler, they have chosen to treat that with the aligners. You can also see a severely tipped molar was here. It was almost an impossible task by the aligner. So what they have done is, they've put bracket onto, locally they have put bracket on those 3 teeth, and they have given a wire in order to correct the tipping of the 2-6 that you can see here in this diagram. And these days, the hybrid approach is gaining popularity. What does this hybrid approach talk about us? Somewhere along with the aligner treatment, the braces are also a part of it. So suppose here you can see rotations, you can see 2, 5 being severely rotated, and the levels are also at different position. In order to correct it, what they have done is, firstly, they have gone ahead and placed the brackets or the slots, and copper nitride, the more flexible wire, they have placed it. Then they have gone in for the scanning, so they could mark the margins and then cut the aligner sheet accordingly. So they went ahead with the appliance placement, then the aligner fabrication. Simultaneously, these 3 teeth corrections were happening, and other teeth were being tracked by the aligner. So that's how they could easily, or with a less number of aligner trays and with less duration, they could finish this case. If these 8 teeth also had to be corrected by aligners, maybe then it was very difficult with, there was need for you to remove a lot of collisions here by doing interproximal reduction, and then place a lot of attachments on the 5 in order to correct it. So that's how somewhere incorporating braces along with the part of aligner treatment is a hybrid method. You can see here, posterior crossbite has been seen in this case. All of you can see this. Posterior crossbite is noticed. So what have they done? They have gone ahead, because it is an adult patient, and just clinically buccal tipping of the posteriors to that extent, around 4-5 mm. Almost it is sitting on the lower middle fossa. So you need to correct around 4 mm in order to get it into correct buccal occlusion. 4 to 5 mm. It is a difficult task with the aligner. So what they have done is temporary anchorage assisted expanders they have placed. They have gone ahead for good amount of expansion with the orthopedic appliance and then given the aligners for the tooth finishing or to move the teeth towards the final position. Here you can see we spoke distalization is giving a promising result, is a much more good option compared to many other tooth movement. Yes, but half cusp class 2 is okay to treat with aligners considering the duration. Imagine you have to move 7 distally first, then you will start moving 6, 5, 4. The number of trays will increase. If the number of trays are increasing, that means to say inevitably the duration is increasing. In order to little reduce and fasten the treatment, here they have given intraoral distalizer appliance initially first. So they have gone ahead with the distalization of the molars and the premolars. Then they have gone ahead with the aligners for final settling. So this is a way where you can reduce the complexity of the cases and make it a moderate one, make it a suitable case for the aligner, and then subjecting the case for the aligners to have better predictability and more predictability of the results. You can see, as we just mentioned, extrusion is a much more difficult one to treat with aligners. So what they have done, see, you can see the slight amount of open bite that you can see here. It is really bothering to the patient and they need to extrude it. But aligners will not extrude a teeth. What they have done is they have placed on a lingual side, they have placed 3 buttons at the exact level where you need to extrude a lateral. So in that manner, they have tried extruding the lateral, not with the aligners, because aligners fails to extrude a teeth effectively. So that's how they have clubbed braces or a component of the fixed appliances with the aligners in order to have a more predictable results. So many of you, when a patient comes to your clinic, you will have the doubt before giving the estimate of the number of the trays. So how will you estimate the number of trays? How do you guess the number of trays required? Because first you need to tell the patient how many trays might be required, how long the treatment can go on, then the cost factor you need to decide. In order to know all these three, you need to first know how to estimate the number of trays. It is very simple. The widely used method so far here is how many millimeters or how many degrees are we correcting with each tray, and what is the malocclusion. I will just give you one example. You need to close 4 mm of space. There is a 4 mm gap that is present in upper arch, but with every tray at maximum 0.2 to 0.25 only you can close. So inevitably to close every 1 mm you require 4 to 5 trays. So in order to close 4 mm of space you require 20 trays. That's how you will calculate the number of trays. So please note down linear movements of 0.2 to 0.25 millimeters only we can move it per tray. Vertically, that is intrusion, even if you are advising of anterior intrusion, if you are advising 0.15 millimeter only you can advise with each tray. When it comes to tipping, torquing and rotation, it is good if you can just correct 1 degree per tray, but imagine a case is having 12 degrees of rotation, 12 degrees of torquing. In order to reduce the number of trays, you can just try 2 degrees, but more ideal one, especially for torque correction, is better to keep 1 degree rotation correction, 1 degree tipping and 1 degree torquing. I'll just give you a clinical scenario and please respond by saying how many trays will be required. Maxillary arch is having 3 millimeter of midline diastema and 25 degrees of rotation in the first premolar. How many trays will be required for a maxillary arch? 3 mm midline diastema and also 25-degree rotation of a premolar. How many trays will be required in order to correct this case? Okay, some of you are saying around 30 sets. To correct to correct torquing, if to correct rotation, if you're keeping 2 degrees, then all that what you can do is 25 degrees of 25 degree needs to get corrected. Around 12 to 13 trays are required in order to correct the rotation. At the same time, 3 mm space had to be closed. Around 15 trays are required. So 15. Now it completely depends on how many degrees you want to derotate. If you're derotating by 1 degree, you will require 25 trays. If you choose, okay, let me take risk, I will go ahead and correct 2 degrees for each tray, then your prediction of 15 trays is correct. Upon this, always add 2 to 3 additional refinement trays and quote it to the patient, because you never know. Practice management is an entirely different thing. The science tells one thing, but patient comes back saying, my pet took away this aligner, I lost the aligner tray, or there can be breakages. Severe proclined teeth have this difficulty. However well the tray is fabricated, the minute the patient wears the puts the tray into the patient's mouth, the plastic doesn't have that much of stretchability. So proclined teeth are at one level, posteriors are at one level. The minute they put on the tray, there will be breakage of the tray somewhere in the canine or the premolar region. So some unexpected outcomes you can see in between the treatment. So better to add on 3 to 4 trays along with the exact number of predictions, whatever you do it. So one thing did you all understand by this? The most severely maloccluded teeth will determine the number of trays. How many of you will agree with me? The most maloccluded individual teeth will determine the number of trays that are required for a case. Is it so, or is it the common malocclusion? See, so why I am telling you this is, there is 30 degree of proclination of a lateral incisor. You need to correct it. You need to, at any cost, you need to correct the lateral incisor by 30 degree, which will require around 30 trays. Irrespective of around 1 mm spacing is generalized spacing is there. That doesn't matter. Within 5 trays, the spacing can get over. In order to correct the torque, you need to continue to extend, giving the trays to correct the torquing. So it becomes necessary for you to see the occlusal photos, or to see the case from occlusal point of view, to see if a particular tooth is rotated, if how many degrees of torquing is there. From you will have to see from all aspects before estimating the number of trays. This second approach of calculating the number of trays is usually not being carried away these days. What they used to do is large increment of tooth movements in the initial stages to show a rapid result to the patient. Later they were getting back like 0.5 to 0.75 mm and all. They were trying to move with the initial trace, but this approach is not good, as the periodontal ligament will go for hyalinization and the tooth movement will just halt. Once you exert so much excessive pressure, once you try to move teeth so much, either the tray will break, the hyalinization can happen, tooth movement will just halt. Unpredictable things will be, you will be noticing. So uniformly distributing the tooth movement among all the trays is what is more expected. Coming to interproximal reduction, like how many millimeters are they suggesting from different companies if you have worked with? Between the tooth, what is the maximum IPR that you should see, and no, it should not cross what amount of IPR? What are they generally advising between the two teeth? And it should not exceed what millimeter? Can anyone of you answer? What is usually advised is 50% of the proximal enamel only can be removed. 50% of the proximal enamel. Do not get confused for 50% of crown thickness. It's just the enamel thickness, 50% only. Roughly what is being told theoretically is measured 1 mm, that is 0.5 mm per proximal surface can be removed from the contact points in the molar region. But when it comes to anterior region, 0.35 or 0.4 and 4, 0.3 and 3, around 0.6 millimeter can be removed from the anterior region. Safest is don't exceed anywhere from one particular contact, don't exceed 0.4, and from another contact again, don't, irrespective of whether it is anterior or posterior, 0.4, 0.4. Altogether, it makes it up for 0.8 in each contact area. Don't try to exceed this. 0.7 is okay, 0.8 is okay. Don't go and vigorously remove 0.5 of each tooth and make it 1 mm in each contact area. No, that is not required. If that is the case, find other methods of treating a case. If there is so much crowding, then you can think about removing one lower incisor, you can think about premolar extractions. Then something is really wrong. You're just forcefully making an extraction case into a non-extraction one, which will end up with a lot of sensitivity to the patient. So just, it's good, it's happy to see 0.6 or 0.7 mm of IPR. That is still, so many people will say, if not done properly, especially between the premolars and all, it is leading to proximal caries after certain years, and a lot of food lodgement is also being seen. So be very cautious when it comes to seeing the IPR report. Be strict and try to reduce the IPR. Maybe if you can incorporate few degrees of proclination, few degrees, I'm saying not much, few degrees instead of doing IPR, try to choose that, try to choose expansion rather than just going for IPR. Now I just want all of you to notice the canine and the lateral incisor over here. When such a case has been given, is it ideal to just go ahead and do interproximal reduction in this case? Definitely, it is not at all a possible movement, not at all a possible task. You'll be stripping on the lingual side of one teeth, you'll be stripping on the mesial side of the another teeth. That is not is what is required. We exactly need to maintain the shape of the proximal contacts of the tooth, and re-give the contact areas. This is a case where you will not do initial interproximal reduction. No, it is not supposed to be advised. So there are many other ways to clear the collision. If given an option, if this was premolar extraction case, take back the 4, take back the canine, and go for reverse orthodontics, wherein you little expose the proximal contacts, then do interproximal reduction, take back the teeth. So that is how, wherein when you see such cases, no, you suddenly don't jump and try to, even if you're trying to do with handheld strips, it is very difficult. You're just touching the other surfaces like buccal surface and the lingual surface of the tooth, and not the proximal surfaces. When it comes to ABCs of interproximal reduction, A refers to definitely these are abrasive agents, right? Whether diamond strip you're trying to use or a disc or a burr you're trying to use, they can hurt the soft tissue. So avoid touching the tongue, lip, and cheek. So for this, you need either forehand dentistry, or you need to properly isolate before doing it. And always brace yourself with a finger rest. At most important, you're using a disc in order to do interproximal reduction in the anterior contact. Suppose slantingly if you go, there is no way for you to correct the slant that or the shift, or the whatever malocclusion you are creating. The midline is never a midline, it is just tilted. Contact between a lateral and a central is again tilted. It looks very unaesthetic, and there is very less ways to correct it. So giving finger rest whenever you are using, especially the disc and the burr, is at most important. Most of the time, actually, the handheld strips, or with the handle you'll get strips, using them is a better idea when it comes to anterior region, because anything with the high speed, you tend to most, how much ever you're carefully doing it, you tend to go here and there and notch into the gingival papillary area. Either it causes bleeding, or slantingly if you do it, you're just the proximal areas or the contacts are being really messed up in the most aesthetic zones. So check for a fully broken contact using dental floss. After you have done with the burr or with the disc, what you can do is take a floss, pass it between it. If there is a fraying of the floss, it is understood that some rough areas are there, or some notch or something has been created. You will have to clear it with using manual strips. You can see here, these are the different armamentarium. With the handle, the strip is available. Purse, again the strip, disc, and different you get strips of different dimensions, different abrasives. It is only one side, it is having abrasive potential, other side it is just the plane. To be more accurate, first you will do it on one side, again turn it across, do it on the other proximal surface. This is the gauge which is used for you to measure it. If you're treating crowded cases, if you're doing interproximal reduction, it is always advised to keep this gauge with you, interproximal gauge, for you to check exactly how many millimeters you're doing. And it is always advised not to do all the IPR at once. Allow the mouth to little by little remineralize, not to bring in so much sensitivity. Let the enamel also, settle down. So better to do it sequentially, but you'll have to note it down. First appointment, how many millimeters you have done. Check it with the gauge. You'll have to maintain a list if you're doing it stepwise. Doing everything at once is really not advised. For doing 0.1, 0.2, 0.3 mm of interproximal reduction in the anterior region, try to use strip only, that too handheld strip only. So that is how you will break the contact. After you have broken, you can check it with the measuring gauge. Using disc, what is the direction? It is not buccolingually, it is incisogingivally. You're not moving it buccolingually, you'll have to go from incisogingval direction. See, and try not to hurt any of the soft tissues. After you have broken the contact, take a floss. What they're doing is trying to pass the floss between the contacts. If it is breaking, then fraying, then it is some rough surfaces are there. Take a strip and try to further smoothen it. Coming to attachments, the composite buttons that are placed on the teeth to further enhance the tooth movement. They act as retention factors. They also help in bringing in a particular directed tooth movement. Usually, remember, you can talk for hours together, days together, just about the attachments. But one basic philosophy is that, firstly, any day tooth movements are little better with the attachments. If you can place retention attachments, if you can place anterior attachments, it is good. The tooth movement is more predictable than without the attachments. And remember, always the vertical attachments help for uh, vertical attachments help for horizontal movements, and at the same time horizontal attachments helps for the vertical movements. You want to extrude a teeth little bit, at least you want to intrude a teeth. If you place a horizontal vertical bar, it tries to help in further intrusion. In the similar way, you want to do mesiodistal tipping, which is a mesiodistal movement or a horizontal movement. You can place a vertical attachment that further gives a good surface area for it to be acted upon, for the forces from aligners to act upon the teeth. So that's how you get to see vertical attachments. You will also get to see horizontal attachments. There is something called as beveled. Beveled is the attachment is being cut at particular degrees in order to create an active surface area. You can see here, it is a distally it is a gingivally beveled attachment. It is gingivally beveled attachment, also little bit placed towards the gingival direction in order to extrude a teeth. You can see here, this is one of the mesially beveled attachment for you to derotate a tooth. A tooth is being way too mesially placed. So for it to distally rotate it, so more forces can be exerted upon the mesial bevel that is being placed. So beveled is further, it increases the surface area and more forces can be exerted onto it. Attachments can be of where and all you can use for angulation correction, derotation, for bodily movement, for intrusion, extrusion, for torque expression. You'll get different shaped attachments. You can see here. You can also give torque elements or negative attachments for torque expression. For extrusion, you can give semi-lunar attachments. Beveled attachments also can be given for extrusion. As we just mentioned, rectangular horizontal for the vertical movements, and rectangular vertical tipped attachments for derotation, and rectangular vertical for derotation bodily movement. Usually, like how many millimeters they are of, it varies. The thickness varies from 2 to 4 millimeter. Sometimes what happens is a properly made rectangular attachment, especially with the uh, uh, proper in the anterior region, the patient will have a lot of difficulty in removal and wearing. Where in such cases, in order to reduce the pain and in order to ease patient for wearing and removing the trays, all that what you can do is such exactly rectangle shaped or some beveled surfaces and all, you can slightly round smoothen it. You can take a composite finishing burr, such rectangle ones, you just try to smoothen those edges so that the wearing and the removal becomes easy. This is clinically you will have to do it because the patient complains a lot of pain will be felt by the patient. Wearing and removal also becomes very difficult, and if they are forcefully trying to remove it, sometimes the tray can break. So to avoid such scenarios, you can smoothen few of the attachments if they are of either horizontally beveled or rectangle shaped, you can smoothen it. Coming to attachment placement, all these days a flowable composite was advised to place the attachment, but now no, because of repeated wearing and removing, it doesn't have sufficient strength to maintain the same shape. So it is advised to use a restorative consistency or a filler, having filler components, a restorative consistency composite to be better used. Some people will try to cut the tray into 2 to 3 halves, apply Vaseline, make holes on the trays. All these are better if avoided. No need to apply Vaseline. No need to cut the tray. What happens when you're cutting the tray? You're pressing the tray with the finger pressure. You might tilt it. You might, one part of it you can just wrongly orient it. Better as a whole tray, all that what you can do is place for one quadrant at a time, then remove the tray, dry the tray, again refill with the composite, do it on the other half on at other interval, but don't try to cut the tray because orientation, tilting of the tray can happen. Try avoid with the restorative consistency composite, match the shade of a tooth and the whatever is more predictive, more suitable composite. Fill it properly. Maybe little excess. Why I'm telling you little excesses. Most of the time, the composite just gets set within the template tray. Within the template tray itself, it gets set. You'll have to remove it. You're all of you. If you have noticed that, then you're failing to do this step. Teeth are mal-occluded. The tray is also in a newer position. If you fail to make the composite touch the tooth surface, how will it bond onto the teeth? So take one instrument, make sure you're adapting the composite onto the tooth surface properly. You can see here, right? Take any blunt instrument, just make sure, or with the thumb pressure, make sure you're pressing the composite and making sure that it is touching the tooth, then going ahead and curing. Or else most of the time, once you remove the tray, it is just coming in the template tray. It is set, but it is set in the template tray and it is not sitting on the tooth. So that's how this is like must do for placing composite attachments. How do you remove it? With high speed handpiece and composite finishing burrs. Pliers can be used again completely. You may not be able to remove it. Just like we debond and then try to squeeze out the composite. Plier can be used, but better is finishing burrs. So far, we discussed what are aligners, to what highest highest levels of treatment, what they're doing from aligners, what are all the difficulties of aligner expressions, and that's why they have come back to hybrid method wherein they're trying to club fixed appliances with the aligner. So now you know what are all the plus points of aligners: tipping, space closure, simple crowding cases where it can get over within 0.2 to 0.3 mm of IPR, wherein no much structure is being destroyed, or smile relapse cases. Yes, these are all good cases to go ahead with the aligners. At the same time, the minute you see severe torquing, severe rotations, anything above 25 degree, above 30 degree of correction expected, means you will go for n number of refinements. To avoid it, maybe locally you can just do some amount of braces or fixed appliances related treatment, then give it to aligners. So that's how it can be done. Coming to diagnosis, irrespective of a case going for braces, self-ligation, lingual, the diagnosis will remain the constant, and that needs to be done in the way exactly it has to be done. So there is no change in the diagnostic factors. You need to give us the correctly diagnosed facts for us. Is there is a gummy smile, way too short upper lip is there. So, and how do you go ahead and correct the gummy smile? Way too short upper lip is there. How much millimeter of intrusion to do? And so these are some of the factors. Is the midline matching, upper and lower midline matching, or is the upper midline shifted to one side? Do you want us to correct the midline, not correct the midline? And canine relation is not class one on one side. So you want us to correct it. How do you want us to correct it? IP or on just one side? And how do you want us to correct the class 1? Can I bring it to class 1 relationship? So there is no change in diagnosis, or whatever patient is expecting, also the treatment expectations will also not change, irrespective of the when do you call it as a successful treatment is functionally and aesthetically none of the factors that the patient wanted has been compromised. So you need to give such results irrespective of the appliance that you're using, whether it is fixed appliance or it is aligners. You need to give those treatment results irrespective of the appliance used. As I was just talking, you will have to provide us with the basic case sheet along with the STL files, such as, you need to mention the gender and age of the patient, because don't you all agree age is a deciding factor for the tooth movement? 12 to 14, 12 to 16, 18 years of people will have a more predicted tooth movement because of bone still being remodeled, wherein adult patients will have a slower tooth movement. Tendency for recession and all is high towards the adults. And when it comes to gender, yes, so many, like, there is definitive difference between how bone moves in a male and a female patient. Coming to chief complaint tells us exactly what is the aesthetic results that the patient is expecting. Coming to facial features, is the face, is there any asymmetry? You need to see the patient's face from frontal view and also from the profile view. You need to evaluate if there is something greatly that is off. Chin deviation, nose deviation, is like, I know that aligners cannot correct a chin deviation, but if that is one of the criteria, you will have to subject them to minor surgical procedures, get the genioplasty done, any adjunctive treatment that needs to be done. There is deviated nasal septum. Why is there a deviated nasal septum? Is it affecting your malocclusion? You just need to correlate. Just look into the overall orofacial structures. Try to, is there any one third of the face is extremely increased? Is the patient averagely growing patient, or severe vertical grower, or severe horizontal grower? Is there a mandibular shift? Dual bite is there? All these things you need to check before sending a case, before referring a case for aligner. Profile, in the profile view, you will have to see whether the patient is having convex profile, straight or concave. Sometimes class 3 cases, upper lip is placed backward, the mandible is placed way too ahead. So what are your plans? If it is growing, the treatment plan will vary. If it is already an adult patient, the treatment plan will vary. So that's how you need to mention these are the concerns for the patient, these are the clinical evaluations that we have made, and these things needs to be addressed from aligner treatment. And also the soft tissue, any habits were present in the patient, any hyperactive musculature that you can see. And also thorough intraoral examination, starting from any recession that is present, any frenal attachment, abnormal frenal attachment, and severe rotations, any retained deciduous teeth. How many of you think that an impacted canine is a good case for aligners? How many of you think you can, without hybrid method, can you treat impacted case with aligners? So that's how it starts becoming difficult for you. No, extrusion is a difficult moment. So impacted canine treating is a difficult one. No, we cannot treat an impacted case with the aligners. You will definitely need some hybrid method in order to correct it. Anterior severe open bite of 4 millimeter. Is it possible with the aligners? Anterior open bite of 4 mm. Is it possible to correct with aligners? Okay, that is also a difficult tooth movement with aligners, wherein spacing of generalized spacing of 4 mm, generalized spacing of 4 mm, that is starting from canine, between canine and premolar, lateral and canine. Yes, yes, spacing is a good case. Spacing we can, maybe at one point, you might have to go for re-scanning and then replanning, but any amount, to an extent, spacing, yes, we can close it. And how many of you have the habit of taking informed consent for the orthodontic treatment? It is better whatever you have decided and whatever you have spoken with the patient, the realistic expectations from the treatment, you just note down and start taking informed consent, because after 1.5 years, neither you nor the patient will remember the exact words that have been exchanged in the clinic. So better start taking the informed consent. These are the 5 extraoral and intraoral photos. You do your own extraoral, intraoral evaluation. You write down your problem list, and also allow us, whoever is planning, for them also to see and evaluate the case. But these are all the static records. The more required one is the not the static one, right? Like when you need to evaluate the smile when the patient is talking, you need to evaluate smile when the patient is smiling. That is possible from your end. Like you need to evaluate, should I really go for intrusion of anteriors in order to correct the deep bite, or I should just intrude lower anteriors because upper smile line is really good. These things you need to really evaluate on in your clinic. These are static records. Dynamic records, if you send us a video, then maybe we will be able to notice, but nothing like meeting a patient in real. So you can notice smile line, the gingival display, how much of interlabial gap is present, what is the nasolabial angle, am I permitted to procline upper teeth, or should I get the lower jaw front, like in order to correct a class 2 condition. These are few things that you just start thinking. It's a class 2 condition. That means either the overall upper jaw can be placed forward, or the teeth have been proclined, on the upper teeth have been proclined, or the lower mandible as such is placed backward, or there is somehow the mandibular teeth have been obstructed, something like in div 2 incisor pattern, the mandible is being uh, held by the upper incisors. So how can we solve this? First, remove the obstruction. It's always a flow chart. It is never one step. It is never just one decision. There are ways to treat it, but what suits best for each patient, you just need to look into it. This is how frontal extraoral, at rest, frontal smiling, oblique photo. This is a patient should be standing in a natural head position, that is where all his musculatures are relaxed, and he'll be staring at a far place, wherein as if a mirror is kept in front of him, and one at rest, one at smiling. Oblique is he has to turn towards 45 degree, and then you'll record one at rest and one at smiling. Profile is the patient in the same natural head position has to turn towards 90 degree in order to for you to take the profile photo. Intraoral, always take in occlusion. Ask the patient to relax and make him repeat in the biting position. Then take it in that biting position, right lateral, frontal, and also the left lateral, upper occlusal and lower occlusal. So what happens here is, suppose one tooth is way too off. So we can see from the occlusal view and predict the more, number of trays and other aspects of the treatment. OPG, if taken for all the cases, it is really good. For very simpler class 1 cases wherein there is the extraoral photo itself is sufficient for profile evaluation, then there is no need for you to go for lateral ceph. OPG will do for us to see the bone levels, to see if any teeth is impacted, to see the status of erupting third molars. Better to always take OPG for every patient, but lateral ceph is an option if it is class 2, if it is class 3 skeletal jaw basis, then maybe you will have to go for lateral ceph. So this is what exactly I was talking about. In orthodontic, the problem can be of upper jaw or lower jaw. Either both can be at fault or any one jaw can be at fault. And also, just not the skeleton, it can be a dentoalveolar component. It can be upper dentoalveolus which is at fault, or the lower dentoalveolus that is at fault. Along with this, you're forgetting the aspect of soft tissue. Sometimes abnormally the upper lip is just too thick, your upper teeth are well inclined, there is no much prognathism, your upper lip thickness is way too ahead. That's why the patient is feeling very prognathic. So it can be a soft tissue factor, it can be a hard tissue like dentoalveolar component, or it can be a skeletal factor that can be contributing to a malocclusion. So it becomes necessary for us to identify what is at fault and try to treat it accordingly. What additional things, generally what happens is spacing cases, you will just refer a case for aligner. So they just look for abnormal frenal attachments. And when is the ideal time to do frenectomy? When you're closing space, what is the ideal time to close to do frenectomy along with space closure? If you're doing frenectomy, when is the ideal time? Is it at the starting? Is it at the ending of the space closure? After ortho, after space closure, yes, last 1 millimeter is remaining, or almost the spaces are closed. That is the time when you can go in for frenectomy. That is the ideal time for you to do the frenectomy. This is very unusual, lower frenal attachments causing the lower midline edema, but you never know, some cases can come up with it. So you can also try to do the lower frenectomy as well. This is what I was talking about, especially in the class 3 cases. The lower anteriors will have very thin bone support. You can see the minute they opened the periosteum, you're able to see the bones directly. So there is no, this is what you can see on a CBCT or on a lateral ceph. If you keenly notice, there is absolutely no bone covering the lower anteriors, lower root surface area. So that is how it is. It becomes difficult in a class 2, in a class 1. So you need to evaluate before retroclining the teeth. You'll feel like, okay, the upper teeth are way too proclined. Let me just torque them. Torquing is crown. You want to move it way too lingually, way too palatally. You'll just start giving torquing, because you have made the plan, you will send the patient, you'll feel like, okay, let me retrocline, the plan seems good. So if you send the patient, what happens is the root is being touched by the cortex, and a lot of uh, root exposure or gingival recession can happen. So just see the plan, start understanding the plan given by whoever it is, step to step, and evaluate it with the intraoral condition. Is this plan suitable for my patient from all tissue point of view? This you need to evaluate, and stage by stage, am I clearing the collision for a tooth to come out? Has the amount of collision been cleared in the plan, and also are you doing it clinically? These are few things you need to really check when you're treating case with the aligners. So there is something called supracrestal fiberotomy that can be done in order to prevent the relapse, or to help the rotation corrections to become into a stable results. This is, see, after the treatment, after the fixed retainers have been placed, it is nothing but anesthetize the area 2 mm into the gingival sulcus. You're just going around the cingulum region and trying to cut those fibers which are going to bring in the relapse of the rotated teeth. So this is called supracrestal fibrotomy. This can be done whenever you see severely rotated cases to have more results, either with braces or with the aligners. This is how your aligner kit will look like. There will be something called, these are essential tools. I'll tell you, the chivis are must. Ask them every time they remove the tray and wearing back, let them bite on the chivis nicely, like from molar to molar, let them bite from one side to the other side. Remover tool, most of the patients will somehow get used to removing the trays with the fingers itself. There is no need for particular remover tool as such. But yes, if at required, at some places, if it is required, let them use it in the initial days. And now I think all of you know the sequence. Initial days, the tray will be tight. On a fourth, fifth day, it starts becoming loose. And for one more week, we are just trying to hold the teeth in the corrected position, and we are not moving to the next tray. In 15 days, initial 4 5 days, the trays will be snugly fitting, or it is somewhat discomfort will be there. Fifth, sixth day, it starts becoming loose. For the next 7 days, why we are keeping the aligner tray in the mouth is to hold the correction in that position before jumping to the next tray. So that's how there are also aligner cleansing solutions that are available. And it becomes at most important for you not to over promise, because present condition, aligners have some, they're not able to give 100% of what has been made in the plan. So if you just over promise, and at the towards the end of the treatment, if the treatment is not happening, maybe you'll have to come back to some fixed appliances and give the results that the patient will be wanting. So with this, I would like to conclude. Take simpler cases. If it is moderate or severe cases, make them as simpler ones with hybrid method, and then take up for the aligners. Maybe in the coming days, shape memory aligners are coming, wherein maybe we can expect better outcomes, better predictability of the tooth movements. But with the present technology, it becomes very difficult for us to take up severe cases. Even if you're taking severe cases, what happens is number of trays will increase. 2 2.5 years, if you're providing support, if you're going ahead with the aligners, the patient also starts becoming non-compliant. 1 year is okay, 1 year, few months are okay, but 2 years and beyond, if the treatment is ongoing, the patient will stop wearing the trays because lifestyle problems and everything. So even he gets frustrated after a certain point. So it is suitable for mild, moderate cases, but for severe cases, better use some hybrid method, make it into a simpler one, and then go ahead with the aligner treatment. There are also softwares that are available to keep the patients engaged. So many aligner tracking applications that are available on the Play Store. You can make your patients download those apps, which will act as reminder. So today is your third day. How many hours did you? They have a self questionnaire kind. So how many hours did you wear it in each day? It acts as a reminder. So alarm will be set by the app on the 15th day, 14th day for the patient to change to the next tray. So this is how some of the apps are there, because more the involvement, the patient will also be happy. And all most of the time, what happens is we the clinicians tend to overdo interproximal reduction, because most of the time the correct armamentarium may not be there at the clinic. So start having that armamentarium, without which you will definitely, if you're taking a crown reduction burst and trying to do IPR, you are removing more enamel than what has been prescribed. Again, to close that, you need to give more trays. So refinement trays, now so many companies, if you see, they promise a lot of refinement trays. If there are 15 trays, again 10 12 trays of refinements they are promising, because if we are taking so many additional trays to actually complete a case. So that's how refinements are a part of aligner treatment. So be prepared for it. Prepare your patients also for it in order to reach that ideal treatment results. One thing is that any doubts, you can post it on the chat box. Thank you everyone for being very patient. Some of the tracking apps you are asking, no, doctor? Okay. Aligner tracker is there, which is available on the Play Store. Aligner tracker and many other software are available. Something like ClinCheck. Yes, ClinCheck is exclusively provided by Invisalign, but we will not have anything like that to compare the tooth movement. The superimposition factors and all such softwares we do not have, or it is not that easily available. On a planning software, you can take a current scan and you can compare, you can go back to the previous scan and overlap it and see if it is happening or not, but not any software for iOS. I'll just check and will inform doctor. Yes, pliers to give crimping and all, the thermoform pliers that you'll get the whole set for it, but you'll have to be more precise at which position you're giving and like where to give to express the torque and all. Like you'll have to, one full set is available, doctor, to give the torque and everything. You'll have to know at which location, cingulum area, label area, where to give for which tooth movement. Better to see patient once in at least 1.5 months to 2 months, not way too beyond it. Try to see patients at least once in 2 months at least. Don't just give the trace and send the patient. Yes, if it is lagging, you need to do backtracking, that is going back to the old aligners. uh yes, if some space, if there is a gap that is noticed between the teeth and the tray, or some fit tissues are there, you will have to go back to few previous trays, or to whichever tray was fitting properly. Like third tray was fitting properly, patient is at seventh, come back to third, let the patient wear 3, 4, 5, 6 for another 5 days at least, and then proceed with the seventh tray. Most of the time backtracking, if the space has been created, solves most of the fit issues, or the tracking again comes back to normalcy. Yes, we can definitely have a detailed session or with the hands-on of IPR and attachment in the coming days. See, so many companies are coming up with the certification programs. Yes, they will have orientation of their own company, how it works, the any, mm, the method of uploading a case, how the trace will be delivered. Each company comes up with their own certification programs that is basically for you to orient them to the mode of functioning. Just like whenever Invisalign does, they talk about ClinCheck, how to upload a case, how the trace are delivered. So, they are just orienting to you and they'll certify you. Every company is almost providing you with the certification. Thank you. Thank you, everyone. We'll be ending the meeting. Thank you. Pricing, yes, the lab charge into 2.5 to 3 times you will have to charge. That is when you can be profitable. Suppose 20,000 is the lab charge. Then you will have to at least start your treatment charges from 60 to 70,000, or else if you're then we will be at risk, because some refinement trace will come up, or some in between refinement scans will have to be done. 2.5 to 3 times is of the lab charges is what you minimal have to charge to the patient. It is under your practice management, doctor. If patient comes back with one losing of one tray, it is left to you. That's why, keeping all that in mind, you will have to charge initially, because even the patient gets irritated in between if you try to ask them for a lost or a damaged tray. So better include some of these unexpected things to happen in the treatment, and take that extra 5,000, take that extra 10,000 rupees, including one additional time of scanning, additional trays that will be required. No, it is never a good idea to get all the trays at once. That too, if patient is not going anywhere, is able to come back, then better to get the trays printed in the stage wise, not at once. IPR burrs, Strauss company burrs are good, but they are pricey. Anything will do from liberal traders, or also so many IPR burrs and discs are available. Just make sure like you're using the most appropriate one, and you know which dimension you're using. It cuts point 2, point 3. You should know like what is the thickness. Everything is these days color coding, and also how many millimeters it cuts. Every detail has been given. You just choose proper armamentarium. Yes, if there is a damaged tray, until you get your next set, the patient can always go back to their previous set and continue to wear that for some days. That's why whenever you are giving aligners, tell the patient not to discard immediately after they are done with each tray. They're supposed to wash it and thoroughly preserve them until they reach next 4 5 sets. They're not supposed to throw their previous trays. They're supposed to preserve them. That's in case of damaged tray, in case of backtracking, they can use them. You can scan a case if fixed orthodontic treatment is going on. You will just get a rough estimate of the plan. You cannot you can virtually remove with the software. You can remove the braces and still go ahead with the plan and printing, but that is not accurate. If you're planning immediately after braces, if you're planning for aligners, better remove the braces and then scan and proceed with the manufacturing. Yes, any of your remineralization paste, or any, firstly Vantage for sensitivity, the toothpaste that have been given for the sensitivity, and also some of remineralizing agents also you can give it to the patient. The mouthwashes having remineralizing potential also you can give it. Yes, if you're doing segmentally the fixed mechanics, place the brackets, then go for the scanning. That is a better way, so that they'll mark the margins on the teeth to which the aligners have to be cut. So yes, if you're going for segmental fixed, then scan after the braces or the tubes have been placed in the mouth. That is the better way. See, not to trouble the patient, better you finish off the extractions few days earlier. After 10 days, you go for scanning. Anyway, you'll take another 1 week for the trace to be delivered. So get over with the extraction and a little bit of initial closure of the socket procedure before scanning and planning. That is a better way of going ahead with the case. So get over with extraction, then go for scanning and trace. Lateral open bite cannot be completely avoided. One option is to start one of the arch treatment in earlier compared to the starting both the arches. Like don't start maxillary and mandibular trace at once. Start one arch initially, like 2 months prior to another arch. This is a way to reduce the lateral open bite, but there is no way to completely avoid it. It inevitably happens because of the intrusion, but later you can close it by buttons and elastics, or you can allow it for natural settling. Ask the patient to chew on a chewing gum on both the sides, both the posteriors, post treatment. That is the way. You cannot completely avoid it, doctor. Yes, they do give class 2 elastics from first tray, but yeah, yes, like it is still like that will not compensate for it, doctor. In only one arch correction, how it works, the posterior open bite will be lesser. I think you're asking regarding the same, right? Or you can choose to do one arch correction. There is no harm as long as there is no overjet problems or anything. So you can do one arch as your overjet, your buccal occlusion should permit.